Yes, dear colleagues, I hope you all had a very good night, are really refreshed now. And I already gave a talk 2 days ago about the dense breast and DBT and focus on the principles. Now I will focus more on the most updated results, and you know that there is always a disclosure, and maybe my statements are a little bit briefed, because I worked also on a white paper study for GE focusing on preoperative IBUS, and I'm an ultrasound specialist besides all the other specializations I have. So this is my outline, and I will focus for the techniques we discussed, DBT and ultrasound, on detection rate, recall rate, size, but I will add also individual cancers. And this is important to know that there are two things. First, the higher risk of very dense breasts compared to fatty breasts is up to factor 4 on one hand, and on the other hand, the masking effect. And this masking effect is responsible that in the extremely dense breast, yes, we miss cancers, and other screening tests such as ultrasound or breast MR, in addition to mammography, in these extremely dense breasts, they add to cancer detection and therefore also to survival. We'll see more details, and this is again hello from my breast center in Osnabrück. And in addition, I would like to focus whether or not size matters, because reducing advanced stages by screening, that's a real principle why screening works, because it increases the breast-specific survival. And also in high aggressive cancers, there are some that metastasize very early, and also for those small size matters, and this is relevant for further survival of our patients. But we are not very sure that small differences of cancer size at the time of diagnosis provided by our better imaging techniques might be so relevant that it will add to the further survival in less aggressive cancers. Why? Because the therapy is extremely good today also for those patients. But this is a very important report from Tabar, who analyzed screening trials. And a major important statement was that whenever screening trials are able to reduce advanced diseases in a range of 20% or more, the breast cancer mortality will be reduced by 28% in those women who have been invited. On the other hand, if the screening trials are not able to reduce the advanced stage disease by 10% or more, there's no better survival at all. So this average reduction of advanced cancers, this is the real reason why screening works. And survivors prefer to have a diagnosis at very early stages. And this is a nice remembrance to the World Congress of the Senologic International Society, where also IBUS had been invited, and Thaddeus and I organized this congress, and ESSO was also part of this congress. So, how high is the real breast density risk? And the answer is clear. It depends on both categories you are comparing. And if you compare, for example, the level 4 extremely dense breast with the extremely fatty breast, the risk factor is increased by factor 4. But if you compare the ACR density 4 with the average density, it's only 1.2. And if you compare 4 to 2, it's the factor 2. So you always have to look at both groups to understand what relative risk means. And here's just a short example what an extremely dense breast looks like. It shows a very hyper-dense stroma and fibrous tissue. You can't really differentiate. and only a little bit fat, and how frequently are these very dense breasts. If you look at US, it's approximately 10%. If you look at the German results, all with digital mammography, it's just 6%. But if people talk about dense breast, they usually combine the level 3 and 4, ACR 3 and 4. And this is not the same sensitivity. In Germany, we have a very good sensitivity of level 3 ACR density, but a poor 50% in level 4. And what's the consequence? The consequence is that also T2 cancers or bigger cancers can be masked by an extremely dense breast. So ultrasound has not a problem finding the diagnosis, but mammography is just dense. And there's another example of an extremely dense breast. But there's a little sign you might know. It's a so-named tenting sign. What's behind that tenting sign? It's a retraction. And if you compare the right-hand side and the left-hand side, there are extended ducts. And if you go further, there are hypoechoic areas. And here we see a hypoechoic architectural distortion made a biopsy using vacuum-assisted biopsy. And it was a multicentric DCIS with macroinvasion and desmoplastic reactions. These are quite old data from Kolb, and Kolb was the first who really emphasized that in the ACR density 4, the sensitivity of mammography is approximately 50% and less compared to ultrasound, which has 75%, 76%. But if we are really honest and looking at the data, mammography was much better in ACR density 2 and 3. But this was a first hint that ultrasound is really superior. But if we are considering about the policy decisions on supplemental screening in high breast density, there are various levels of arguments. First, there must be evidence on the increase in breast cancer detection expressed by the detection rate, and maybe also the tumor size accounts at the time of detection. But then we also have to look at the resources and the human costs of the diagnostic activity that is reflected by recall and biopsy rates. And finally, just have a closer look on the definitions of dense and extremely dense tissue subgroups in this population. Now it's a little bit scientific, and there's a real very good survey on DBT in radiology in May, and you don't have to take all this data on a glance, because we will go very structured by these data. And here you have a nice example of a synthetic case of DBT, and these in both planes, MLO and CC. Looks very innocent, but if you go to ultrasound, it's no longer innocent. It's more sagittal than horizontal. There are microspeculations. So this is a cancer NOS. So what is relevant looking at the detection rate? We have to compare digital mammography, full field digital mammography alone, with full field digital mammography plus DBT. And compared with digital mammography alone, the breast cancer screening with DBT plus digital mammography increases the detection rate in a range between 1.2 and 4.6 per 1,000 examinations. And this increase occurs in both in the dense and the fatty breasts due to the improved lesion conspicuity across all density levels. That's very important. But the unmasking of cancers occurs particularly in the dense breasts and very dense breasts. So your short message is there are improved screening outcomes with digital breast tomosynthesis, including higher cancer detection rates. If you look at the recall rates, In Europe, we have heterogeneous results because our primary recall rates were much lower compared to US. But this is only one study, the Malmö study, and the average is just showing a reduction of recall rates, and this reduction is much stronger in US, where the recall rates go down up to minus 60% and more. And this is because they start with very high recall rates, which has a connection to the medical-legal surroundings. So these lower recall rates of asymmetries and focal asymmetries are secondary to the unmasking of superimposed tissues, and the higher recall rates of masses and distortions is also secondary to the unmasking of real lesions. So both principles and improved screening outcomes with digital breast tomosynthesis, including lower recalls, that's the message. Another case, very difficult to see something maybe here on the synthetic image, but this area shows some irregularity, some distortions, and this is a cancer, and it was a DCIS grade 3 with a lot of desmoplastic reactions. If you look now at the biopsy rates, they are 1.4 to 1.6%, and this is lower, the real biopsy rate, compared to the recall from screening, which is between 5% and less than 30%. But the initial round of DBT screening may be associated with an increased rate of biopsy, but that returns to a similar level of FFDM at the subsequent screening rounds. And the biopsies generated from DBT findings are associated with a higher cancer outcome. That's also important. But overall, there's no significant difference in screening studies to FFDM. So another case, synthetic case, and it's really difficult to find on this case the root cause of this metastatic lymph node. It's this little finding, quite innocent, but if you look at ultrasound, this is not really innocent. This is a very typical cancer with all the criteria, and look at the irregular margins. So very easy to find in ultrasound, very difficult to assess by DBT. Once again, we compare digital versus DBT plus digital, and if you look at the tumor characteristics in the Verona and the Norwegian screening study, the additional invasive cancers detected with DBT tended to be first smaller, second lower grade, and they had a more favored prognosis. This is quite important to understand. We have less aggressive tumors with a lot of desmoplastic reaction that are in addition detected by DBT. Once again, a case with segmental calcifications, difficult to assess on the screen, and a little mass, and the final diagnosis was both an NOS grade 2 and an DCS grade 3. Let's go back to the tumor size at time of diagnosis. This is not really often commented in the literature, but I feel it's important, and if you look at the screen-detected cancers that are invasive, the average in these studies is 1.1 centimeter currently. And in DCIS, it's a little bit bigger, 1.3. But if you look at the interval cancers, they are quite bigger, nearly 2 centimeters, and the interval DCIS in comparison are smaller than the primary DCIS detected at screening. So this is a new standard. If you just keep in mind 1.1 for mammography, this helps to compare it with older data. But to be very clear, there's no significant difference in screening studies between DBT and screening mammography. Now have a look at interval cancer rates. And there are not much data. The rates are between 0.5 and and 1.2 per 1,000 screens, which is not very much, but analysis and comparison of these rates of interval breast cancer in women screened with DPT are very necessary to fully understand a potential overdiagnosis. And currently, we believe that overdiagnosis is maybe 10%. It's very clear what overdiagnosis is. It means you're detecting a cancer early, you treat it successfully, but the lady has not any advantage by it. Why? Because she dies by any other cause. So the advantages of the early diagnosis and treatment cannot be transferred to this woman. That's overdiagnosis. So now we are at ultrasound. Again, detection rate, recall, biopsy rate, size, and interval cancers. And if you look at meta-analysis, older meta-analysis, there is a pre-selection to intermediate risk patients, and there is no question that currently ultrasound and mammography, or better mammography and ultrasound, have become the standard modalities to screening these ladies. In most countries, it's not MRI in Europe. And if you look at such a case, we see an innocent mammography. It was from our screening practice. We added again the right-hand side. There was nothing to see on mammography. But if you look at ultrasound, this is a clear-cut, hypervascularized heart cancer. And 3D ultrasound, in addition, shows you that there are architectural distortion of the surrounding, so clear cancer and additional DCIS. This is the latest meta-analysis, and I don't want to go too much into the details, but if you compare the data, overall results by density division, there is a very clear-cut message. The message is the proportion of only ultrasound total cancers was 29%. And this is a 40% increase in the detection of cancers compared to mammography alone. So this is not too bad. Looking at the latest meta-analysis that adds IBUS also to handheld ultrasound, we have to summarize that the additional 3.8 in a random analysis or random pattern of the statistical analysis 4.0 screen detected cases per 1,000 negative mammographies, and about 13% of cancers were in situ cancers. Dense breast ultrasound, who is best? And the question is physicians or technicians. And if we compare these studies, which are quite historical, sometimes we see that the screen detection rate of physicians is better compared to technicians, and this is particularly true if there are multi-center studies. So you are better than the technicians if you go to IBUS courses. And here is a nice example that ultrasound can also detect important, relevant changes even if mammography is stable. And this mammography was completely stable over many years, but we see that there is an ultrasound interval change, and this interval change looks like a cancer. It's hypervascularized, it's shadowing, there's an architectural distortion, and there's here in 3D, you can see it very easily. And here we make the diagnosis by a large corneal biopsy. And astonishingly also, the whole area is hard. Why? Because the diagnosis was a lobular invasive cancer, and there was associated CLIS in the surrounding. So, recall rates. Who is best? Now we are comparing handheld studies with IBUS studies, and you see that there is a high variabilities of the single-center and multi-center handheld studies. I would like to focus on between 6 and 10%, and Athena, who is our real big specialist in IBUS, and she has nearly greatest experience, not worldwide, but in Europe. She will comment more on the IBUS data, but you see there's one study that has a very low recall rate. I will comment on this later. And this is how such a study looks like. And you see here a cancer, and this cancer is just not so far distance from the nipple, and the nipple can be found by looking at this yellow dot. This is a help by the analysis system, and here we see how it looks like if you go through the volume in the coronal planes, and I repeat it for you. You see here the nipple, the cancer showing up like a little dot, but if you go through it transversely, you see it's much more like a little black dot. It's a real cancer. What about the biopsy rates of handheld ultrasound and IBUS in the meta-analysis 2016? We see that there are quite high biopsy rates, but on the other hand, the higher the biopsy rate and the recall rate, the more cancers and the smaller cancers you will detect. This is another case from our center. Yellow dot means nipple, and here we have an NOS at the 3 o'clock position, and it was already T2, G3, but no lymph node metastasis. And what about the size at time of diagnosis? I just want to go too much into details, but Corsetti from Italy, he had excellent results for ultrasound when he focused on ultrasound detected cancers in the dense breast. And we had much more cancers and interval cancers detected by ultrasound compared to mammography. And these cancers were detected at a low stage compared to mammography. So this is an important message without going more into details. And if you look at the average size in North Italy, it's not precisely stated in his publication, but you can recalculate it. Then his results were excellently. The mean size in mammography was 1.3, and ultrasound was, let me say, 0.8 centimeter. This is an excellent result that is achieved also by MR studies. And if we look at the size in these meta-analysis, only 3 studies are able to show you something about the size, which is not really good. Another case of our NOS G1 here next to the nipple, and you can very nicely see the architectural distortions around the hypoechoic center in ultrasound. That is the advantage of the coronal plane. And if you look at Austria, there's a very old study from Buchberger in 2000, but also he, with this old technology, was able to have a mean size in ultrasound of 0.9 and mean size mammography of 1.1. And if I might remind you, this is what the modern DPT studies in Norwegian, for example, also achieves now. So the Austrians are very good. What about Sweden? And this is the study with the low recall rates. The cancers are horribly big, 2 centimeters. This is nothing you can be proud of. So I'm not very impressed by this average size of cancer. And then we have the Akron study, a very famous study of our good friend Wendy Berg. And Wendy was quite okay, but there were no statistical differences in size between mammography and ultrasound if you look at the whole collective. It was 1.3 and 1.2. But we learned a lot of important messages from the Akron study. Even it's a little bit older now, and the technology was not first class at that time. The most important point is that we detect similar number of cancers, and cancers are here invasive and non-invasive, total cancer detection rate. But we detected more, or Wendy and her colleagues detected more ultrasound cancers than mammography cancers, and ultrasound detected more lymph-negative cancers compared to mammography. So a lot of important messages. And here is another IBUS image, and this looks quite impressively, this cancer in ultrasound. In IBUS, here you see the diagnosis. Now I show you the mammography after positioning a clip, and there's nothing you see in mammography. And here we see the surgical specimen. Do you see any cancer? It's included, you don't see it. So it's no question there are mammography negative cancers. So to repeat the gain in knowledge by Ekrin 6666, the cancers seen only on screening ultrasound were all stage T2 or lower, and among the invasive cancers, 1/3, 33.7%, were seen only with ultrasound and 20.2% only with mammography. So both are complementary. And dense breast interval cancers, they are difficult to assess from the literature. But again, Course.2019 did a very good job, Wendy did a good job, and the number was between 1 and 3 per 1,000. And this is a Japanese study. And this Japanese study is the only that compare mammography only versus mammography and ultrasound. And it is a doubling of the interval cancer rate if you have only mammography. But it's quite low, 0.4 per 1,000, not very high. So the statement is nevertheless, it's lower with mammography and ultrasound than by mammography alone. What are the future directions? If I summarize the current benchmark, and this current benchmark focuses on Biopsy Rates standards for mammography, this is too high. You should be able to detect in a modern population-based screening system smaller cancers than 40 millimeters. This is historic, what Biopsy Rates writes. And the detection rate here may be okay. Ultrasound should be, this is Biopsy Rate standard again, at 10 millimeters. And DBT is 11 millimeter. MR, there's only one study by Christiane Kuhl from Aachen in Germany, was 8 millimeter. If you look at the additional detection rate, it's best for MRI. And it's very similar for ultrasound and DBT in the newest studies, but the N0 stage is lowest or highest in ultrasound. So this just detects those with the best prognosis. And I just mentioned the study of Tavlerico, and this is a very important study that compares DBT and ultrasound. And the most important message is that of 24 additional detected cancers, 23 were detected by ultrasound and only 13 by DBT. Nevertheless, I told you DBT went its way and has a coverage of 60% now in Germany, in US. Ultrasound still is helpful, but it's not implemented within a national system, with one exception, Austria. And let me come back at the end at the survival depending on size. And survival has become much better. If you look at the data before 2005 and after 2005, you see that the small levels have a much better survival, but all the others also. And this is due to better diagnosis and better therapy. There's an additional point. It's helpful, and Alan Mendelsohn made this statement and showed me this study, that you spend much more money in a health system for advanced breast cancer compared to early breast cancers. So it's wise to focus on the early cancers. There's no question that the cancer-specific mortality, including the breast cancer-specific mortality, goes down in the last years worldwide in the Western countries. But if we try to analyze what is the impact of screening and what is the impact of therapy and the surrounding environment, there are nothing else than computer calculations to help us to understand this question. And if you look at the survival with no screening or treatment environment, the survival is very poor. If you look at screening only, it's similar up to 95, and screening only versus treatment only is better now for treatment only due to the enormous increase in advances of therapy. But if you look at the combination screening and treatment, this really offers the best survival, and this is the best mode to do both, best screening and best therapy. So we come to summary and take-home message, and again, one of these nice coronal images that show you the architectural distortion in cancer, even if the lady is quite old, and she had a bilobulated tumor extension and simulated growth in handheld ultrasound, but MRI clearly showed it's just one cancer. Take-home message 1. DBT leads to the extra detection of 2 to 4 screen-detected cancers per 1,000 negative mammographies. Handheld delivers 4 screen-detected extra cases per 1,000 negative mammography, and IBUS delivers 2 screen-detected extra cases per 1,000 negative mammographies. And DBT is going to develop from a supplemental screening tool to a standard screening tool. And I thank you very much for your attention.